All right, our next presentation is going to be an opportunities and utilization review, which is a really, really important topic because in my experience of many, many years of working for non-clinical careers with physicians, for physicians that transition into this work, it's probably the number one thing that they do is some form of utilization review. And our presenter, Dr. Moles, is going to um, talk about that. So we're very pleased to have Dr. Rebecca Lynn Moles back as our presenter. If you remember, Rebecca was one of our keynote speakers. Fantastic presentation that I will encourage you to check out if you haven't already seen. Dr. Moles is a child abuse pediatrician who transitioned from academic medicine to health insurance utilization management as a medical director for Elevance. She is a certified professional coach with a special interest in physician burnout in early and mid-career physicians. Dr. Moles is a Sikh alumna. She has she has had faculty appointments at UConn, Yale, and UMass. She earned her BA and MD at the University of Rochester, completed her internal medicine and pediatrics residency at UMass and Worcester, and her child abuse pediatrics fellowship at Brown. And she's a certified coach from IPEC, if I'm saying that correctly, Dr. Moles. So anyhow, welcome back, Dr. Moles, and thank you for doing double the work for us.
Thank you so much. And thanks to all of you who decided to click on this option out of all the different courses that you could have chosen. For the next about 40 minutes, I'm going to tell you what I know about utilization management. And as Jim mentioned, I attended the in-person version of this conference in 2018. And when I showed up there, eager to learn about different types of ways that doctors could spend their time, I knew exactly nothing about utilization management. So I put together this talk for the me of 2018 as someone who didn't know much about it, and I'm trying to answer for you the questions that I had, and then pepper in information that I've gained along the way that now that I work in that space. As Jim also mentioned, you may recognize me if you watched my keynote that's available to you. And if you didn't watch it, what are you doing? That obviously should come first before this. Not only will it help set you up for getting the most out of this whole course, but it also will give you a bit more of my background. I invite you to go ahead and pause me now and go watch that. In case you didn't, or you already forgot what my background was, as Jim mentioned, my entire clinical career, which was about 20 years, I was doing child abuse pediatrics, so super subspecialized niche of pediatrics. In 2018, I came to the SEEK conference. I learned about utilization management as well as several other things and did a few things in the interim. I never had any idea that I was going to actually do utilization management, but in 2021, I handed in my resignation, walked away from my clinical career as a child abuse pediatrician, and took a full-time job at an insurance company doing utilization management. That's where I'm coming from, and here are the questions that I put together to answer for you today. What even is utilization management, right? This was my big question in 2018. We're going to go over that. What do doctors do who do this work? Where do they do it? Meaning physically, where are they? And also for what organizations, for whom? What do I even need to know to even do this job? How does it feel, right? How does it feel to do this job? What's the day-to-day like? How do I get experience in this type of field? How do I get noticed out of the different doctors who might want to do this work? And then, of course, how much could I get paid? So let's jump in. What even is utilization management? I am not kidding when I used to hear those words and just be like, la, 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 I don't know what they're even talking about. If you use that beautiful AI feature of the Google search, it will tell you that utilization management, also called utilization review, UR, but is a process that assesses the necessity and efficiency of medical treatments, procedures, and facilities. A cost containment strategy helps ensure that patients get the right care at the right time while avoiding unnecessary or inappropriate care. Okay, that's still kind of chewy. Really, what it means is you're reviewing things to see if they're medically needed. More on that as we go through. So what do the doctors do who are actually doing this utilization management work? So as you know, there's all kinds of things that are asked for, right? Tests, procedures, Medications asked for an insurance company to pay for. Hospitals ask for payment for inpatient or observation level of care for people that are admitted to the hospital. And then patients ask to see providers that are inside or out of the network of their health plan, or to be seen in a hospital, or to go to a lab that's maybe not part of their health plan. All of these things have to get reviewed, and reviewed for if they're medically necessary. Many of those things do not ever need to come in front of a doctor. So every time you order like a CBC or an X-ray, it's not a doctor at an insurance company who's looking to see if that's needed. But many things do need to go in front of a doctor depending on what the type of test it is. So all of those different things that are asked for get reviewed for medical necessity. And the way we do that is reviewing the notes or information that's sent in with the ask. So looking at the patient records, other tests, etc. And then you're making a decision about if we're approving that or not, and using different criteria, which I'll talk about, to help decide if it's medically needed. Then I'm also the person who then writes a letter to the patient to explain to them why something is being approved or denied. Generally, the patients don't get a letter from a doctor telling them why it's approved. They'll just get like it's an approved letter. But we write the denial letters to help explain to the patient why it is that the insurance company is saying no to this request. If any of you have ever looked at that for yourself, or as your own patient, or you're the provider looking at those, every different state and different markets within each state have rules about how those letters have to be written. I happen to work in a market where the letters have to be written in 4th grade reading level language. So that means very small words, short sentences, not very complex, can't have many syllables, can't have a lot of complex sentences. So if you ever looked at one of those and thought, this is so silly the way they wrote that, it's likely because of those types of rules. So I'm working on distilling down a lot of information into some short sentences to help explain to the patient why their test isn't covered. If something is denied, then it can go to the peer-to-peer process. So that would mean where the doctor who's ordering the test is talking directly to a doctor like me working at an insurance company and talking about why it was denied, sharing more additional information that can help with the process. If something is still then denied, it can go to the appeals process, and that's when another doctor looks at the same case. It's like a second opinion, essentially, and more information can be provided. So working in the field, doing this type of utilization management work, you're doing all of these pieces. So I'm the person who's calling and doing peer-to-peers, I'm doing appeals, I'm doing the initial reviews. Hopefully that clarifies a little bit about what you're doing for the bulk of the work you're doing when you're doing this type of work. What you don't do when you're the doctor who's doing this is see patients. So many people do utilization review or management work and also have a clinical role and see patients. And that is fine. That can happen as long as there's not a conflict of interest and you're not seeing the patients that have your health plan. But as the role of working for an insurance company or for other organizations that do utilization management, you're not seeing the patients, you're not their provider. So you're not ordering tests or medicines. So I had to leave behind that feeling of being the person in charge of their care or making the decisions about which tests. So the way that the insurance companies phrase it is they say, we do not direct care. So that means that if you send in a request for a certain test, let's say for like a facet injection of the back, back joints for pain, but the notes that you send say that you really want an epidural steroid injection, I have to deny that because what you asked for is not what you said you wanted. I can't say, oh, you know what? Dr. So-and-so really wanted this, so let's just change the code to match what they wanted. Nope, because that would be directing care. We have to actually make sure that what is tested for and what is asked for is what's being asked for and make that aligned. So this is a departure from the way that you're likely used to practicing medicine because you're not actually practicing medicine. You're not the doctor for the patient. All right. So where do people do this? Where do doctors do this? The majority of doctors who are working in this field are working for an insurance company. So there'll be these national large insurance companies, names like Aetna, United Health, Humira, all those types of places. And then they have lines of business or different health plans within that large company. So they could have a health plan that functions in Kentucky and something else in Nebraska. And there'll be overlaps, but there are very different market specific things that are needed. So a doctor who works in one of those markets might not necessarily know all the nuances of the other market, if that makes sense. You can also work for commercial insurance. That would be like you have from your provider or you purchased yourself, or government sides would be Medicaid or Medicare. All different rules, different types of strategies that have to be applied there. You can also work for a place called an independent review organization or an IRO. So these are third-party companies, so not hospital systems or healthcare systems, and not insurance, but a separate organization whose whole role it is to provide medical necessity review on cases. So they could be hired by hospitals, they could be hired by insurance companies, and they will often hire different subspecialists and generalists to do these types of reviews. So as you can imagine, insurance companies cannot employ one of every single kind of doctor in the universe, but there can be times that they need a very specific type of specialist to review a case. So an IRO can be very helpful in that because they can have doctors on a kind of a panel, they call it, where you might get called every once in a while to review a case in your super subspecialty niche. We'll talk more about those as we go through. Most insurance company jobs in general are full-time. Some are part-time. There can be similar part-time things at an IRO. Like I said, there's a panel where you become one of multiple doctors who are employed on a contracted basis. So as a case-by-case kind of ad hoc, more of a side gig, as people would call it, or a side job. Most of the time, this is remote work. So there's not a brick and mortar building that you go to do this most of the time. I happen to work at a company that requires me to go to an office once a week. It's a company mandate, but it's not necessarily that I need to be there to do the work I'm doing. So most of this is remote work from home. And we'll talk about the skills that you need for that work a little bit later. One question I had in 2018 when I first learned about this, and in 2021 when I was considering taking this job, is what do I even know to do this job? And I have to tell you, as a super subspecialized pediatric child abuse doctor, I was like, do I even have enough experience with different types of medicine to do this job? And the answer is yes, I do. I'll tell you more about that. But what you generally need to have is board certification. Some places will say eligible, but the majority of them want you to be board certified in your field. If you are a subspecialist, you don't necessarily need the generalist. So if you are a gastroenterologist, you don't necessarily need internal medicine and gastroenterology, but board certified in something. You need to be licensed in at least one state, and most of the time get licensed in more than one state for the company or wherever you're going to be doing the reviews. And then for the majority of these positions, you need clinical practice experience beyond training. And for most of them are looking for 5 years or more of clinical practice experience. So those of you who are in medical school or residency now and looking to transition to a non-clinical job immediately, this likely is not going to be for you. And in a lot of ways, that makes sense because what these companies, the insurance companies or the IROs, are trying to do is have doctors who have real life experience taking care of patients, helping to decide if tests and procedures that are asked for are medically necessary. So they want you to have more than just the book smarts, more than the training smarts, but the actual some street credibility, if you will, for having done this type of work. So they're going to be looking for clinical practice experience. The knowledge base that you need to have is obviously going to be about your specialty, right? It's going to be what you've learned along the way, especially if you're doing it for a job where they're specifically looking for a specific specialty or for one of those independent review organizations that has a specific niche that they're needed. When you're reviewing for medical necessity, as we talked about, you're using your own clinical judgment as well as many other resources. There are third-party published criteria or guidelines that most insurance companies will subscribe to, and you have access to those. So that has a lot of different criteria for different types of tests and prerequisites of things that have to happen before you can get a certain test. Things like you have to have a certain amount of physical therapy before you can have surgery on your back, like those types of things. And so those are at your disposal, as well as one thing I was very excited about to learn that I had no idea about at the insurance company I work at is that there is a whole group of doctors and scientists who work for the insurance company who come up with internal company guidelines to help determine if things are medically necessary. And their whole job all the time is to review medical literature and constantly update the guidelines that they're using. So it's not these antiquated old dusty guidelines from a long time ago. They're constantly reviewing, constantly updating them. And when we look at them, there's a whole bunch of footnotes. There's all of the different studies that they're looking at. So all of that is at your disposal as well. So that comes back to what I said about, no matter what specialty you have, you can do this job because you have other things at your disposal. You also, of course, can use things like UpToDate and the things you would regularly use in your clinical practice, and Google searching and PubMed and those things that you would use to find different studies and support to help understand what they're asking for and is it medically needed. All right, and now we're up to how does it feel, right? How does it feel to do this job, to work in an insurance company? So the first thing I got to address is, does it feel like you went to the dark side, right? So I get this comment mostly from other physicians, like some from other colleagues who are still practicing clinical medicine. Oh, are you the person that I talk to when I do the peer-to-peer? Most of like regular people, so what I by regular people, I mean those people in my life who are not medical in any way, don't see it this way. And I will tell you, it's not like every day I get up and I put on my sinister Disney villain music and my dark cape and my angry eyebrows and start thinking about how I can deny people things and be mean, right? It does not feel like that on a day-to-day basis. I work the closest with other physicians and nurses in my health plan. And we are constantly talking about what's best for the members, the patients, what is the right thing? How do we get the information we need to be able to get them the care that they need? So it does not feel like I'm going to work every day at like a dirty job. I certainly, as I mentioned already, feel like I'm using my medical knowledge in a different way. I happen to have trained in internal medicine and pediatrics before fellowship, so I feel like I kind of dusted off my internal medicine knowledge that I had from residency. And just about every day, I'm hearing about some new medication or some new treatment or something that I have not thought about before or even known existed. And I find that interesting. I also find that I can advocate for patients. So I'm at the level of reviewing what's coming in. I can see the trends and help to flag that for the higher administration to say, here's what's going on with our members, here's what they need. I've now been working at this company for about 3 years, and I feel like I'm just stepping into this role because I, as I mentioned, didn't know a lot about utilization management when I started. So the first couple of years, I was just basically figuring it out. And now I'm getting a bit more of understanding the workings of it to be able to make more meaningful change in the organization. So I certainly feel like I'm adding value to the company by making sure that the things that we are covering are the right things, helping with the patients, helping them to understand why we're covering things and not, and getting them what we need. I try to always include, we can't cover this thing for you, but there are other things your doctor can order that might be right for you, and trying to redirect them to something that could work. And I also feel like I'm adding to the providers. So have been interested to learn. So you hear so much about all the fraud, or not fraud, all the waste in medical care and the system. And one big reason that I end up having to deny things is because I don't get the information I need to approve it. And there's a lot of different reasons that is, but one big thing, and I'm sure this will come not as a surprise to those of you who are working in clinical medicine, is that the documentation is not great. EMR is wonderful, but copy and paste is terrible. And so I can't always tell what's new information, what's old, What's the current information? And I need that information in order to justify saying yes or no to a specific ask. So as an example, I was just reviewing the other day a review for an ask for a wound vac. So a special treatment for serious wounds that are not healing with underlying conditions like diabetes, et cetera. So I was reviewing the notes from a person who was in the hospital for several days for this complicated wound. And I, as part of that review, have to look to see how deep is the wound, how big is the wound, what has been tried. And every single note said, left leg, wound. That's it. And I kept looking and nobody described it, nobody talked about it, nobody measured it. And I was like, there's just not enough information. A left leg wound could be a paper cut, right? Like I can't tell what it is. So I have made sure that when I am talking to doctors and the providers during the peer-to-peers, that I'm explaining to them what I needed. And if it's the certain situations, I'll say, here's the information we didn't get. If you could include these things in your notes, if you have a template in Epic or whatever EMR, if you could add these things, it would help us to know what we need, to have what we need when you send it in. There's also issues that sometimes the doctor's notes are good, but whoever sends in the request to the medical company, to the insurance company, doesn't send the right note or doesn't send the right information. So sometimes there's an internal kind of snafu in how those things work. So I try to point that out as well. The goal being that we don't want to spend our time in committee in paperwork and keep doctors from providing care and patients from getting it. So that's all the ways I feel like I add benefit. I also do not feel like I am pressured to deny care in order for a profit for the company. And when I was looking at my job, I said to the person who was interviewing me, is there a certain percentage of things I have to deny? And they, no joke, laughed out loud. And they were like, no, no, no. And that's that like dark side mentality that I was going into thinking that's what I was doing. As a matter of fact, for my company, I have to sign a thing every year that says that I'm not being pressured to deny medical things for a profit. And I feel no problem signing it because it's true. Back to how it feels. I will also say that my busiest day still feels slower. And by slower, I mean just more manageable, less harried, just kind of less obnoxious than when I was doing clinical work in a hospital. And that does not mean I'm not busy, and we'll talk about that, but it just feels at a pace that's much more reasonable, even on my busiest day. And some of that is that nothing is life or death, right? I'm not getting paged to intubate somebody. So it's even if there's a decision that has to be made or something that quickly needs to be turned around or there's something that's expedited and it has to happen right away, it's still not like the patient's going to die if I don't get there or I'm making some life or death decision about them. It's also, there's not overnight call. I don't have a pager. So it's much easier to have clear boundaries about when I'm working and when I'm not working, even though I'm at home. We'll talk about that. It also has been interesting. So I worked my whole career in relatively small children's hospitals or children's hospitals within bigger hospitals, but generally small places. And now I work at a company that's about 100,000 people, and maybe 400 of us are doctors. That's a very different feeling than working in a hospital system where honestly, I don't know what the ratio was of doctors to everybody else, but I feel like everybody knew what the doctors did, right? They were the ones seeing the patients. They were the ones in the hallway wearing their scrubs, right? We knew what they were doing. Now it's easy to feel like a cog in the wheel, to be honest. We're doing a very important role. They have to have doctors working there. But there's a lot of corporate initiatives and mandatory emails and trainings that I look at and think this really has nothing to do with what I do every day. So that's a little bit different than feeling like it was to work in a hospital system. And I will also say for me, I feel like I walked away from my career and now I have a job. So what I mean by that is that I felt like when I was working, certainly in academic medicine, right, I could never do enough, right? It was all about, should I be writing a lecture for the medical students? Should I be publishing? I need to join this committee. I need to do this. I have to get my charting done on time. I have to do all of these things, all to advance, advance, advance. Now I have what I feel like regular people feel like. And what I mean by regular people is not physicians and not somebody who has spent their career in academics, because I have a job where I turn on my computer and I do my work. And then at the end of the day, I turn off my computer and I don't really think about my job again. Certainly not the way I used to. And it's so much healthier for me. There are definitely physicians who work in the utilization management sphere and have a career in it, right? They're advancing up the company, they're doing things. We'll talk about promotion opportunities in a little while. As I said, I'm a couple years in. I don't necessarily feel like it's a career for me now, and I'm okay with that. So that's a bit about how it feels, and I'm hoping I answered your questions about that piece. All right, so how do I get experience in this without walking away and taking a job like I did? So we talked about these independent review organizations, and there is a national association, NARO. We'll look at that website, and that is a group that these IROs have to apply and get approval to be full members. So there are other independent review organizations that are not part of that, but this is a good way. These are the kind of the vetted companies, a good place to start. Also, there are opportunities to do it on the doctor side of the house, not the insurance company side. So a lot of larger hospital systems are going to have a physician advisor or some type of role. So that's a PA, but not a physician assistant, not a clinical role. But physician advisors who work for hospitals are doing things like reviewing denials and saying, are they medically necessary or not? And they are often the ones who do the peer-to-peers on behalf of all the hospitalists or all the inpatient docs. So some of them do it full time and remotely. There are some companies that do it full time, and then the hospital system orders the hospital system will hire that company to do it for them as a third party. And some of them do it that they see patients and as part of their time, they're doing a physician advisor. So there might be something like that in your hospital system. There might be something similar if you work in a large health system, even if it's not hospital, there might be something like that for offices. There might be ways that you can be on the quality committee and some ways to get some type of utilization management experience other than taking a full-time job. And then the other experience is you learn on the job. As I mentioned, I just happened to know nothing about it when I started, and they taught me everything that I needed to know. So in terms of getting started with experience, this is a screenshot from the NARO website that I was talking about. And if you go to this members section, here's a little screenshot. It'll bring up something that looks like this. This is just one section of it. These are all the different full members, and you can click on each one of them, and it'll take you to their websites, and you can see what they're looking for, what their mission is, and if they have any openings. And if you click right on it, they'll say like our panel of doctors, and you can see what they're looking for. I also included here, this is just a quick snapshot from my LinkedIn search that I did. You can see here, the top here, medical director utilization management in the United States. So that's what I searched for, got all these results. Now, some of these results are not really that, like the director of case management at Nuvance is not what we're looking for. But you're looking for things like medical director, associate medical director. And I clicked on this one for Humana, right? And you'll see here the range of salary that they have. Now, I would say that's a little bit higher than I have seen, but we'll talk about that. But if you can click on there and you can actually keep clicking and it'll come up with the required qualifications. So it has this, use your skills to make an impact. And here's the things we already talked about. An MD degree, 5+ years of clinical patient care experience post-residency, right? Board certification, unrestricted license, you're not in trouble with the law, with the government, and the standard, you can communicate and you can figure problems out, right? That's the must have. Then they have these preferred qualifications for this specific job, Medicare experience or Medicare Advantage. Similar to other things you've heard, you need to probably have all of this top part. You don't necessarily have to have all their preferred qualifications before you can apply. But this is just to show you kind of what it'll show online. And different than if you are, depending on where you are in your career, when you used to have to like send in a paper application, these things are available and you can do them automatically online, which means that they get tons and tons of these types of applicants. So we're going to talk about that. Because then how do I get noticed, right? How are you noticed out of this sea of other applicants that you could see for this type of job? So some of it is going to be your specific skill set. Like as I said, certainly the IROs are often looking for specific skill sets. Certain health plans, certain insurance companies are sometimes looking for very specific types. Like you can be looking for an OBGYN or radiology or something like that. So sometimes it'll be your qualifications that set you apart. The other things that help you get noticed is persistence. So you are likely going to have to send lots and lots and lots of applications to different places in order to get noticed. This is different than probably your experience with getting a clinical job. Once you get past the like, please let me into medical school and please let me into residency and please let me into your fellowship, and you start looking at jobs as an attending, they're relatively easy to get. Doesn't mean you can always get the exact perfect job in the exact perfect town in the exact perfect, school district that you want. But in general, they're relatively easy to get a clinical job. This is so much more applications that they're getting per physician opening that you're going to have to really work hard to get noticed. That being said, it's also going to really matter who you know. The way that I got into this is that my medical school roommate was working at this insurance company and reached out to me and said, we're looking for pediatricians. Are you interested in looking? You cannot overemphasize knowing someone. So you really need to network. One way is through the in-person version of the SEEK conference, has a ton of networking opportunities, and certainly other conferences you go to. But don't discount interactions you're having in your daily life. So it could be people in your specialty, it could be people in your hospital, it could be the person you're doing the peer-to-peer with. So we have somebody on my team right now at the insurance company who was working as a physician advisor, and we used to talk to him on the phone doing peer-to-peers, and now he came and worked with us. He left the hospital system and came to us. So if there's people that you talk to doing your peer-to-peers, you might talk to the same person or not, but don't feel embarrassed about asking them, like, hey, how did you get this job? And what do you like about it? Like, just ask them, because they're not the Disney villains in the dark cape. They're just people at the other end of the phone who used to be like you, seeing patients, and now they're doing this other job. So ask them. Also think about things like your medical school class, your residency class, doctors from other areas, as well as regular people, right? So people in your life, in your town, in your network of, your people that are at your church or belong to some group that you do or coach your kids, because they likely, if somebody works for an insurance company, remember I told you my insurance company, 100,000 employees, right? So they work in some capacity. They don't have to be a doctor there in order to refer you and put in some internal thing to their HR recruiting team to help pick you out of the masses. So do not underestimate the concept about networking. All right, and now, how much could I get paid? Like so many things, it depends, right? And it's going to depend a lot on the company, the type of work, and where you live. Because again, these national companies do a lot of research about where you live and the cost of living, because a lot of their employees are remote, so they're used to doing that. If you're doing like those cases, like I said, if you're on a panel at an IRO and you're doing a case by case on kind of an ad hoc basis, the pay might be pretty small. I'm not sure it's as small as $20, but I put that there because I think it could be. And it could be per case, or sometimes they do it per hour. Now, that could sound really small, but if you are doing reviews for your subspecialty, your bread and butter, the stuff you think about all day, every day, once you learn how to navigate their software and download the things and where you put your note and all of that kind of stuff, the actual medical decision making for you is probably going to be pretty quick, because you know what you're looking for, you know what you're not looking for, you know what it means, You're not like me, a pediatric child abuse doctor who's like, okay, wait a minute, we're doing vein grafting for claudication, and you have to like look up what it even means, right? You're looking at things that you're used to looking at, and that small compensation will not take you a long time and will get you that experience that you're looking for. If you get a role as a more of a full-time person, I put like a 200 to 300,000. That's a wide range, but I would guess it's more like the low to mid 200s for starting. Now, for some of you, that can be a step down from what you're used to getting. I can tell you for me, even as a rare board certified child abuse pediatrician who was relatively well paid in my field, I ended up with a larger base salary taking this job than I had working for my children's hospital. You also have to remember that you're working generally 40 hours a week for real, not 40 hours a week on paper, but 80 hours a week for real, right? Like I said, there's very little nighttime or weekend work. I have there's some different things we have to do on the weekends at times, but generally nothing at all like when I was doing clinical work. There's also merit increases. There's true cost of living raises for a lot of the companies, meaning not 0.5%, but 2 or 3%. There's corporate bonuses that I found to be so much more robust than anything I got in clinical medicine. So in clinical medicine, I feel like if I think back, maybe certain times, maybe I got a bonus of like $2,500, and that was for killing myself with my RVUs, teaching everybody under the sun, medical students, residents, being on a million committees, right? And they'd be like, congratulations, here's $2,000, right? This is more, the corporate bonuses now are more like 10 or 20% of your salary. So a huge amount compared to what I was used to getting in academics. They also, of course, have 401k that's very robust and those types of things, as well as stock options, which I was like, what is a stock option? That's a different talk. But they have other things that they reward you with, as well as there's so many less other costs, which are minor, but really add up. So costs like I don't have to commute, so I don't buy nearly as much gas, wear and tear on my car. I don't have to pay parking fees, which I've had to at certain hospitals. I don't have to have real clothes, right? My clothing budget, not that I was ever like super well dressed, but like I wear yoga pants and sneakers. Like I don't have to actually have clothing. So if you are somebody who has a big clothing budget or dry cleaning or those types of things, all of that is going by the wayside. One thing that I have found that is very different though is that they don't have robust CME budget, so continuing medical education budget, which I've just found I just have to pay for it myself. They offer things internal to the company, and that's going to be, I don't know what they offer from other companies, but I have found that different than academics, where I feel like I usually had anywhere from $2,000 to $4,000 at my disposal for conferences, et cetera. That is not the case where I work now. I'm not sure since I've transitioned shortly after COVID, I'm not sure if that has changed for a lot of academic practices as well, as a lot of things have gone to virtual conferences and a lot of CME offerings that are on demand. All right, so that's the how much I could get paid. So hopefully now we have gone through and answered for you a lot of these questions, which hopefully are what brought you here to find out this information. I also wanted to add to you just some lessons that I have learned doing this for a couple of years. I've obviously peppered in a lot of that during this talk, but I have learned that there is a ton of corporate lingo. So if you can remember your first couple of days on your OB/GYN rotation in medical school, where you realize that everything has a 3-letter acronym that sounds almost the same and you have to figure out what it means. Yeah, there's a lot of that in the corporate world, and I'm still figuring that out. Some of it is corporate stuff, some of it is insurance specific stuff. And again, I was very green and naive about insurance stuff. So some of you might not have as much of a learning curve about that. But I still feel like sometimes I'm asking, like, what is that? What does that mean? Because it's again, caters to those 100,000 employees and not to the 400 doctors, right? So they talk in a different language. I also had to learn how to start a new job completely remotely. and how to meet a team and work with people every single day who I have never met, who I have never walked by, who I will never run into. It's very different skill set. And I struggle every day to try to figure out how to connect with people and make it fun. So, as you might be surprised, doing child abuse medicine, a lot of how we survived was by making things fun. So I'm always trying to ask the people I'm working with something silly or share something about what's going on in my environment because it actually just makes it more real. So that's a skill set I've had to learn. With that, working from home is a skill. Like you need to be focused. And if you are somebody who has trouble completing your charts or trouble kind of working independently, this may not be the right kind of job for you because you're not going to have people around you that are kind of keeping you focused or keeping you honest, to be honest. I'm not saying that you're doing something dishonest, but just keeping you focused on what you're working on. So for me, I had to set up an office. So I'm in an office in my house because I knew that I was going to need to have a space that I knew that I was doing. It's like I'm dating myself now, but like Mr. Rogers comes home and he takes off his work clothes and he puts on like his home clothes and his home sneakers. Like I have to have like feel like I'm going to work. A colleague of mine has a table set up. Literally, she can touch it from her bed and has her all of her computer stuff sit there and she just gets out of bed and sits there. I don't have that kind of focus. Like it's amazing to me that she can sit like right there next to her bed and do her work like that all day. But it's everybody's to each their own, right? So you have to have a space that helps you stay focused. And it's also important to know that working from home is still working. So I've had a lot of people who ask me, who say, oh, I want to retire and I only want to work a little. So I thought I would get a full-time remote job. Okay, so full time, right? It is full time. I am working all day. Yes, I have more flexibility than when I was doing clinical medicine in terms of I can pause work and like go pick up my kid from school type of thing, differently than when you have patients waiting and you can't just walk out and do that. But I still have enough work to fill an entire day and I'm expected to be working. And some companies even track things like how many keystrokes are you doing? So make sure that you're not just walking away from your computer and not doing work. You're also, they watch how many cases you're doing, etc. So it's still working. So this is important for you to know, as well as setting boundaries for others. So a big person I have to set boundaries for is my mom, who lives like a mile from me and still 3 years in can't understand that she can't just knock on my door and stop over to tell me all of the things that happened to her today because I'm actually working. It's a work day. So you have to have boundaries for people around you and for yourself to make sure that you stay focused. I also found that there's not necessarily the same clarity or opportunities for promotion as I felt like there were in academic medicine. So in academics, certainly there's the assistant professor, associate professor, full professor ladder, right? And you know kind of what you need to do, and you're constantly working on those academic pursuits to help you gain that. And then there might be things like you're the medical director and then the division chief and the chair and that type of progression. It's a bit different in the corporate world, and there are people who come in, and the entry level for this is called in many companies a medical director. So you already come in as this title as a medical director. Does not mean I'm directing a team. It just is, that's just the title. There are people who've worked at these companies for 10 years or more and are a medical director the same as they were the moment they walked in. And they're doing, similar jobs, like they clearly are gaining skills and they might have little projects, but they're not necessarily moving up in the company. And as you move up in the company, you tend to get more and more corporate. So if that may or may not be your interest. So you're not necessarily getting more and more specialized medical projects. You might be getting more about how is the health plan working on the global level? So it depends on what kind of opportunities you're looking for. It's also a lot of difference between government, so Medicaid and Medicare, versus commercial in terms of what's covered, what's not covered, the mentality about it. So there's a lot of different things to learn there. And I learned that this is a really competitive market. Again, I told you this opportunity kind of fell in my lap at the right place, the right time, but it is hard for people who are trying to break into it. And again, network, network, network. All right, so overall, for me, I have found that utilization management does not have the highs that I had in clinical work. It does not have that I'm looking in the face of the child or the parent whose life I have changed with the care that I have given. I don't get that sense. I also have found that it doesn't have the lows of the clinical work. It doesn't have that pace, that feeling like you can never do enough, that threatening feeling like if you do something wrong, someone's going to die, right? Or you're going to get sued. So it doesn't have those types of lows. So I used to describe that my day-to-day work in clinical medicine was like highs and lows and highs and lows. And now I'm kind of like, kind of in the middle. And that's okay. Because with any job, there are stimulating parts and there are really tedious aspects, right? And the bread and butter of what you're doing for this type of work is sitting in front of a computer. I actually have 3 screens, right? Sitting in front of my screens, looking at cases and reviewing records and making these decisions over and over all day without that interpersonal contact like I was used to from clinical. So that part can get tedious. However, it does have flexibility, like I said, that there's not, when I need to take time off, I don't have to reschedule 100 patients. The pace generally is very sustainable and the compensation is very reasonable for the work that I'm doing. And as I mentioned, I don't feel like I'm like working on the dark side. So that's all great. So tying back to the keynote that we've talked about a couple times, for yourself, as you're considering if this is an option for you, remember to ask yourself, what are you running from? What made you purchase this course? Click on this option. Think about this as a choice. Why are you thinking about leaving clinical medicine or pivoting away from it in some ways? So think about what you're running from and also what you're running towards. Think about what need would this fill for you beyond financial. And also remember to think about not only what you could do, because I'm telling you, you could do this, to what do you want to do? And is it this, or is this a stepping stone on the way? And those are questions that I can't answer for you, but that hopefully you can start to delve into as you go through this process and click on all the different offerings. So I have a couple different resources. These first couple things are actually podcasts where they're interviewing a man named Jonathan Vitale, who is also a Sikh alum, who is a more of a career person in utilization management. He's I believe, a family physician. But he talks about a lot of the things I talked about. So if you want to have reinforcement of this or hear it from a different perspective, there's different ways. There's a lot of other podcasts or coaches who do this type of work into non-clinical career that you can find. That's the website for the independent review organization website, the NARROW, as well as that same doctor I'm talking about, Dr. Vitale, started a Facebook group that's called Physician Non-Clinical Career Hunters. So if you're a Facebook person, you can go to that and you can hear about different jobs that are posted and hear similar questions and kind of start to delve into that side of the world. And with that, I thank you for your attention, and I hope that you came away from this with a better understanding of what utilization management is and what opportunities there could be for you. So thanks so much.
Thank you so much, Dr. Moles. Nobody would know that you're fighting off a cold, wouldn't know it. Fantastic as always. A few questions if I could have been furiously taking notes here. Just
Sure.
curious, when you are doing your oral communicating as a home-based person in your particular company, is it default Zoom or something Teams that's video, or is it just voice only?
Great. So we happen to use Teams at my company, but I would say 99% of the time, the cameras are off, which was a huge change to me from clinical work and working at the hospital where even remote meetings, the camera's on. So that gets into similar to what I was saying about you have to get in the right mindset of working from home because you can legitimately be in your pajamas, so you have to actually, make sure that you have your brain on and be awake and ready to go.
Excellent. And now, Obviously, you're trained in and certified in peds and internal medicine and which covers a lot of things. But you're not a surgeon, you're not a proceduralist. How often do you call to make calls um, outside of your specialty, approving a surgical procedure, things like that?
That's a great question. So I would say a couple things. So there's a lot of different things that I'm looking, that I get asked to review. If there is something that I am not comfortable with, there are other doctors on my team that are my first resource that I can go to. So we have like a palliative care doctor and an endocrinologist and an ophthalmologist, like those types of things. So I can ask those very subspecialty specific questions. We also have resources to have other subspecialists look at things like outside of my immediate team. So I always feel like I have resources that I can call on. And also in my particular company, very specific things. So like spine surgery, other types of neurosurgery, or like chemotherapy, those types of things are often done by more subspecialty physicians in the company. And then they come to me to kind of add whatever is needed to fit the rules of my specific state.
Have
So
you oh,
go
I'm
ahead.
sorry, I didn't want to interrupt you, Doc.
I was just gonna say, so I don't feel like that I'm always at the fringe of my comfort zone, if that makes sense. I have resources to ask.
Is it fair to say that it's kind of fun and interesting to learn these areas of medicine, like OBGYN, that you haven't seen since your internship and things like that?
Yes, like I said, I learn something new every day, and I feel like it helps. I actually feel in some ways more relevant than I did doing child abuse work, because that was so subspecialized that there was a lot of kind of regular medicine stuff that I didn't even know was happening. So now I know a lot
So,
about that.
oh, sorry. So obviously there's a lot of employers, and you mentioned obviously you're saying you're going to take your kid on college tours soon. If you had to pick them up at school, you could do that, sure. Um, at least with your employer, how flexible are they to saying, "Well, I want to work 7 to 3 instead of 9 to 5"? Is it like you have so many cases and you get them done, or do they need you at your desk between 9 and 6 or something like that?
Right. So I have not had the ability in my company to say that I was going to do like a different shift. Like it's almost what you're saying. Like I'll just be
Yeah,
available from 7 to 3, right?
yeah.
Because there are things that, and again, that's going to have to do with the certain market because there are things that have to be done by end of business day, right? Which is 5 o'clock. So there are a lot of times that there's things that have to be done by the end of the day. There are certainly things that kind of roll in all day long. So I have to kind of be on top of it and looking to see. But if I need to be gone for a doctor's appointment that I have to go to in person or a Zoom doctor's appointment, I can step away and do that and then go back and catch up on what I'm doing. But it's not, I'm glad you asked that because I think that people have this concept of when you work from home that you can like do all your work from 10 to 11 o'clock at night when you're super awake if you're that kind of person. Not really, because you're working at a company where other people are relying on what you do and they work regular hours. So I write the letters to the members, the patients, but then it goes to somebody who has to send out the letter. So they have to have it done, during that day so that they can work on it. So there's not the type of flexibility that you're talking about, Jim.
Thank you. And how many, just a ballpark, I know it's going to vary, but how many cases do you think you're dealing with a day that different or patients? I know they're not your patient, but they're patients. Like what's the volume in an 8 hour day ballpark?
Right. So it varies day to day. And I will also give the caveat that there are cases that are really quick, right? And that there are cases that take much longer. Similar to, I would imagine, in clinical practice, where you have, I mean, pediatrics, right? Like the ear infection visit versus the like rheumatologic disorder, not otherwise special, not otherwise specified visit, those types of things. But I would say it varies between probably 20 and 50 different patient cases that I would be interacting with in different ways. Not all of them am I writing a letter for, but I also talk to nurses about patients in the hospital, et cetera. So the pace is faster than I was used to in child abuse medicine, where we saw a few patients for a really long time, but maybe different than for other providers.
Is the system that they have at your employer sophisticated so they don't give you 50 complicated ones and no simple ones? Does that kind of work itself out that you're not getting overwhelmed?
Right. It kind of works itself out. And I also happen to work with a really great team. And we recognize that some days are really busy for me and light for somebody else, other doctors. And we are constantly kind of covering for each other. Or we can always say, like, hey, SOS, like I've got a lot of cases. Can somebody help? And then they jump in and help. So it has been manageable for sure.
In your experience, and for doctors that wanted to do this, is moonlighting allowed? So, for example, I'm an ER doctor, or I want to do urgent care or ER on a weekend and stuff like that. Or if you had obviously you have a consulting practice and business, they let you do that, obviously. But what's your experience with moonlighting?
Sure, yes. So there's they have to make sure that there's not a conflict of interest. So if you are working for an insurance company, I think that they have rules about what percentage of patients you would see would be also have your insurance. Because you can imagine it's a conflict of interest. If I'm seeing you as a patient and then I'm asking the company I work for to approve the procedure that I'm asking for. So there's some rules about that, but as long as you're fulfilling those rules, there's not any problem with you seeing patients. As a matter of fact, they kind of like it because it keeps you clinically relevant. So as long as it's not interfering with the job you're doing, we have people on my team who do moonlighting on weekends or, work in a clinic, a couple of nights a week, that type of thing. So it's certainly okay.
And thank you so much. And do you need a license? You kind of alluded to this maybe. Do you need a license in every state where the patient is located if you're doing this work? And how many licenses do you have now?
Sure. So, yes. So I primarily work for the state of Florida in the state of Florida. So I have a Florida license, but I live in Connecticut. So I currently have a Connecticut license because this is where I live. I don't need that necessarily for my job, but I have a Florida license, which is what I'm using day in and day out. My company also has us get licenses for the other states in our region. That's so that we could, if needed, cross cover if certain plans if they have doctor turnover or they have an issue. So I have, I believe, 4 other state licenses right now and might have to get a fifth. So it does become administratively, you have to keep track of how many CME hours you need for each one, and stay on top of that. The company, though, pays for all of the fees of that. They'll pay for all of the licensing fees, et cetera.
Do they pay for the boards as well? We have to retake the
Yes.
boards.
Yes,
Excellent.
and all of the licensing fees, et cetera. Yep.
So peer-to-peers, what percentage of them would you say get worked out? They just need to document something better as opposed to denied is denied is denied at the end of the
Hmm.
day. Because a lot, like I think you gave a good example with the vacuum thing. If it's a big nasty wound, it's been there a long time, probably approve it. If it's a paper cut, no. It does an excellent
Right.
example.
That's a good question. I've never actually thought about the percentage of it, and because they're all so different, and it's again, I'm not held to some standard that I get my percentage every week, or month that, because it's not a
Right.
metric that they're watching. I think in some ways the company watches it to make sure that I don't approve everything because that would be a problem, right? There should be certain things I'm denying. So as long as I don't stand out among my peers, in one way or the other. I would say though that one thing that I have been surprised about for peer-to-peers is that the majority of them are much more pleasant than people act. Like, so people sound like, oh, I gotta argue with the insurance company, right? And some of it is, I think, my demeanor because I come at it to say, here's what I know. What didn't I know? Like, what did I miss? Help me know what's missing. And then sometimes, it is a denial. It needs to stay a denial for reasons. And I'm explaining to the doctor why. And then they're like, oh, that makes sense. And actually, a lot of the things that I do now are with those physician advisors that I talked about, which are doctors working for the hospitals. And in some ways, those are the easiest ones because they understand the way the insurance companies things and they're looking at the same guidelines. And sometimes we get on the phone and they say, this is totally an observation patient. I don't know why we're even on the phone. Like they take 2 seconds. They're like, this person was a clear cut asthmatic, came in overnight, got better, went home. I don't, like this should not be inpatient level of care. And then we're like, bye, see you later. Like so they're not nearly as like gut-wrenching argumentative the way that I think some people have experienced them.
And you mentioned that when you write the denial letters to the patient, they have to be done at like a fourth grade level. They have to be understandable, which is fair enough. Are you allowed to, or can you use AI to try to tweak your language to make it more understandable?
Yes, so we do have some AI capabilities that they're exploring within our company. There's certainly rules about using any AI technology and putting protected health information in.
Yeah, yeah.
But I will say that writing it in the fourth grade level, I think is very specific to the Florida market. Other places I think are higher, and seventh grade is a lot more difficult, a lot easier to write to than a fourth grade level. And I would say as a pediatrician, in some ways it came easy for me to talk in a fourth grade level because that's kind of the way you do it. Like, we know you came to the hospital for belly pain. You had tests. You did not have dangerous problems. I mean? Like, that's kind of the way that pediatricians talk sometimes. So it came easier to me. But it is certainly a skill that you learn, and there's tools that they have where we try to standardize some of the language. So it gets easier as you do it.
As a person that's standing in Florida right now with the short sleeves while you're on the snow, I'm insulted. But anyhow, um, can you tell me, can you tell us a little bit more about your coaching practice and who you help and how you help them?
Sure. And actually, that reminds me, one thing I didn't say is that having this role compared to having my clinical job is I do feel like when I turn off my computer at the end of the day, I actually have physical time and emotional and social bandwidth to like have a hobby. This was like a big deal, because I suddenly was like, I have free time at night when I'm not completely exhausted. So that ties into what you're asking me because I am, as you mentioned, a certified coach. I came into that after I came to Seek the first time in 2018. So I enjoy meeting with physicians who are doing some type of transitions. So they can be thinking about what's next step. They've gotten their feet wet in their academic world, or their attending hood, so to speak, and now they're trying to design their career. I'm not trying to get people to leave clinical medicine. I want to help physicians build the careers that they love, that fill their need and fill their dreams, and help them to know what that is. So I work with physicians one-on-one, and I also have done workshops and other things within hospital systems to help with that.
And the last question I forget on your first slide, how would anybody get in touch with you if they wanted to get some coaching from you?
Oh,
Was it on
sure.
your first slide, doctor? I don't
I
remember.
think it was on my first slide, but no, the easiest way is actually through my very generic email address. And I'm also on LinkedIn, so you can connect with me there. And both of them are Rebecca Moles, but my email address is Dr. Moles with no period. So DRMOLES @gmail.com. It's easier for me if you put coaching in the subject line so that it doesn't get mixed up with all of my other stuff.
Thank you very much, Dr. Moles.
Thank you.